this presentation is to highlight the importance of reflection. Reflection is very important. We have to do it in every aspect in our lives, let alone when in our work, when we are dealing with patients. So the purpose of reflection is helping us to develop our understanding more deeply and to make our intuitive knowledge shareable with others. This is according to the MIT researchers. And this includes a close look up at our mistakes. More concretely defining those mistakes can help us avoid them in the future. So I'm going to tell you the way that I used to reflect on my cases or the patients that I used to operate on, and based on what I learned in UK. So basically, there is a logbook in UK. It's called ISCP. Any trainee there has to have an account in the ISCP website. And there are so many things that can be entered, including case-based discussions, learning agreements, and one of them is adding a journal entry. If you look at this, there are some highlighted. There is the lines underlined with red. It states clearly that when you are entering something into your reflective journal, you have to make sure that the patient details are kept anonymous, okay? And sometimes they also flag it to you that this can be used for medical legal aspects if needed. So basically, yes, this is what they do in UK, but here in Egypt, I do that, but I do keep all the patient details and records, because here in Egypt, we don't keep an excellent, we are not top edge in the record keeping of patients. So part of it relies on the surgeon himself, who is he or she who is operating. So basically, Hirschsprung disease, as all my colleagues here are aware of, is an agangliosis of the colon. It can be either a short segment, as in the picture over there, or a long complete segment, total colonic, as on the one on your right-hand side. These are pictures of the intraoperative appearance. We use also Lone Star retractor because, as you already know, Lone Star retractor avoids retraction of the anal canal and hence, causing incontinence to the patient. The picture on top is an example of a short colonic agangliosis, and the one at the bottom is a total colonic agangliosis, showing that the total colon has been removed intraoperatively and we came down with an ileostomy. So basically, this is it. This is my journal. We have a sheet in our ish in which we have to write down operative details. Not many surgeons are complying with this, but me as a surgeon, I'd like to enter all the patient details. Ideally you should anonymize all these the names and the hospital number, but I do keep it for my record, even with the telephone number. So it's important, and you have to keep a record of your own operations so that you can follow up your patients and track your own progress. We don't have an ISCP, a website here in Egypt. We don't have it, so you have to create it yourself, and in order to keep track of your progress. So what did I came up with? From 2018 to 2022, I've operated on 35 patients, but we need to drop 2020 because all elective surgeries were cancelled. So Hirschsprung, unfortunately, was considered an elective operation. It was cancelled. We didn't operate. I probably operated only on one single patient. I did about 35 patients during that period, 28 of which were males and 8 females, which reflects the incidence in literature. It's more common in males than females. There are four patients for over 5 years. This is something historical, which is 5 years old. This is really, and I did it single stage. 4 patients had total colonic agangliosis. In all patients, I did Swenson technique, which is like the total mesorectal excision in adults. It's unlike SWABI. SWABI, you have to remove the mucosa, do a mucosectomy, and keep a muscle cuff. The danger of Swenson is that there is a liability to injure the surrounding structures like the vagina, the prostate, the urethra, and things like that, and you can cause injury if you are not completely aware of the layer that you are moving in. So the learning curve. In my first 5 patients, I needed in 5 operations, I needed my colleagues to be with me, scrubbed in with me, my more senior colleagues. And after that, I managed to operate on my own. I did 14 lab assisted, 7 transanal, 18 transabdominal. Complications, had one who needed a reoperation, and 2 who had wound infection and were managed conservatively, and some urine retention post-operative, but managed to be managed conservatively. So when I asked the secretary to come up with a number of patients I operated, she came up with 26 patients. This is really surprising. There's this discrepancy between hospital records and my records because they have wrong coding of the patients. When a patient has a colostomy and does a Hirschsprung operation, it says they write it down as closure of stoma, or that's it. They don't label the patient properly. So, like I have got 10 patients missed completely from the hospital record. So this is an evidence that our reporting needs to be perfected. I'm not saying it's bad. We are working on it, and I've noticed that there is a remarkable improvement, and but it needs to be better. Pathology report. When I was going through my records, I noticed that I don't keep a clear note of the segment length that has to be resected. Is it a short segment or long segment? So especially in my early recordings, this is something that helps me improve my recording later on, that I need to write down whether this was a short or a long segment. So, but luckily, in the pathologists usually write the length of the segment that was resected. So, this is something for me to learn from. So basically, keeping a good record of patients. I'm not saying that my recording is excellent. It's far from being excellent. And really, the amount of effort I'm doing to do that is really tremendous. But I'm just saying that paying details to enough attention to the details you write about your operation will help you a lot following up your patients, your progress, and it's very important to pay attention to details. And thank you.
في أي سؤال دكتور هبة؟ شكرا دكتور هبة.